Now, let's talk about porcelain gallbladder, which you might have heard of. Calcification of a gallbladder can be due to chronic cholecystitis. This happens mainly in overweight female patients of middle age, and it is usually found incidentally on imaging, which you can see here. There is an association with high rates of gallbladder carcinoma, so prophylactic cholecystectomy is recommended. Okay, let's move on to the pancreas. Pancreatitis is characterized by the autodigestion of pancreatic tissue by pancreatic enzymes. There are many causes which are summarized by the mnemonic "get smashed." However, the most common causes are the first two, gallstones and alcohol. The other cases do occur, but rarely, so make sure you know about gallstones and alcohol, and then study the rest. The less common causes listed here are trauma, steroids, mumps, autoimmune disease, scorpion sting, hypercalcemia, hypertriglyceridemia, ERCP, that would be an iatrogenic cause, and as a side effect of various drugs, another iatrogenic cause. The clinical presentation is simply epigastric abdominal pain, usually radiating to the back, along with anorexia and nausea. Labs should show an elevated amylase and lipase, with lipase being more specific. Effects of pancreatitis on the body include DIC, ARDS, diffuse fat necrosis, hypocalcemia, pseudocyst formation, which is lined by a granulation tissue rather than epithelium and can lead to hemorrhage, infection, and multi-organ failure. It can be very life-threatening. Here is a board's relevant question. Which enzyme is mainly responsible for acute necrotizing pancreatitis? The answer is trypsin, since trypsin and trypsinogen act in a positive feedback loop, which we discussed in physiology. This then digests away the pancreas. Chronic pancreatitis refers to a condition patients develop where they keep getting episodes of abdominal pain, though it can progress to constant pain. Additionally, because the pancreatic tissue has chronic inflammation and is progressively harmed, this leads to atrophy and calcification of the pancreas. Patients develop pancreatic insufficiency. Do you remember how pancreatic insufficiency presents? That's right. Pancreatic insufficiency presents with steatorrhea, fat-soluble vitamin deficiency, and diabetes. The reasons for transition from acute to chronic pancreatitis are not entirely clear. Chronic calcifying pancreatitis does have the association with both alcoholism and smoking. There's also a significant increased risk of pancreatic cancer. In comparison to acute pancreatitis, amylase and lipase are less elevated. Our last topic for the pathology section is pancreatic cancer. Pancreatic cancer generally refers to adenocarcinoma, which is the tumor histology in about 85% of cases. Unfortunately, the prognosis is quite poor for these patients, with a prognosis of about a year to 6 months or less. The tumor is quite aggressive and generally has metastasized by the time of presentation. It arises from the pancreatic ducts with glandular structure and cellular infiltration. Here you can see a pancreatic head tumor. Cancer of the pancreatic head gives the classic presentation of obstructive jaundice. There is an increased risk among both Jewish and African American males, and the main risk factors are cigarettes and chronic pancreatitis. The tumor markers tracked for this disease are CA19-9 and CEA, which is less specific. There is a typical clinical presentation with abdominal pain radiating to the back and weight loss. Migratory thrombophlebitis, known as Trousseau's syndrome, can be seen, and this refers to redness and tenderness on palpation of the extremities. As we mentioned, obstructive jaundice occurs particularly when the tumor is in the head of the pancreas, and when the gallbladder is palpable but non-tender. This is called Courvoisier's sign. On the boards, when you see painless jaundice, think of pancreatic cancer in the pancreatic head obstructing the bile duct. Treatment for pancreatic cancer is commonly chemotherapy and radiation therapy. A Whipple procedure can also be performed. This is where the distal segments of the stomach, the first and second portions of the duodenum, the head of the pancreas, the common bile duct, and the gallbladder are all removed. Okay, let's finish up with a board-style question. Concerned parents bring their 4-week-old infant into the pediatrician, noting yellowing of the skin, gray-colored stools, and dark urine that stains their son's diaper. The infant was born full term. Meconium and first-pass stools were normal in color. Physical examination reveals scleral icterus, jaundice, and hepatomegaly. Laboratory studies reveal moderate transaminitis and persistent elevations of the serine alkaline phosphatase, as well as direct hyperbilirubinemia. Liver biopsy shows normal cellular architecture with evidence of cholestasis. The physician explains that the absence of bile in the infant's small intestine explains the gray-colored stools. What substance accounts for the patient's darkened urine? Is it A, conjugated bilirubin, B, sterocoblin, C, unconjugated bilirubin, D, urobilin, or E, urobilinogen? So the correct answer is A, conjugated bilirubin. Let's go through why this is the answer. So this patient presents with a typical findings consistent with biliary atresia. In biliary atresia, there's obliteration of the extrahepatic biliary tree, leading to neonatal cholestasis. The lack of bile flow changes the color of the infant's stools. This is known as acholic stools, and it leads also to an increase in conjugated or direct bilirubin in the blood. Conjugated bilirubin is highly water-soluble, and it's readily filtered at the glomerulus. This means that it will appear in the urine with increasing levels in plasma. The other answers here are incorrect. Let's go through why each one of these isn't right. So B is incorrect because sterocoblin is identical to urobilin. However, these are bacterial metabolites that are subsequently oxidized, giving both feces and urine their color. Unconjugated bilirubin, remember, is tightly bound to albumin, so it's not excreted in the urine. Therefore, it can't be accounting for the patient's darkened urine. D isn't correct since urobilin is a colored compound that normally gives urine its color. However, it's an oxidized product of urobilinogen, and in persistent cholestasis, the bacterial flora of the gut isn't exposed to bilirubin, so it can't make urobilinogen. Therefore, urobilin can't be accounting for the patient's darkened urine since it was never made from the urobilinogen. Again, E isn't correct since urobilinogen isn't able to be made by the bacterial metabolism of the conjugated bilirubin in the gut. So, all in all, biliary atresia manifests with scleral icterus, jaundice, hepatosplenomegaly, acholic stools, and increased direct or conjugated bilirubin. This conjugated bilirubin is what causes the darkened urine. Okay, let's now do another question. A 45-year-old woman with a history of cholelithiasis presents with generalized cramping abdominal pain. She noticed the pain 2 days ago on waking and says it has been getting progressively worse. She has been nauseated but has no bouts of emesis. She cannot remember her last bowel movement. On physical exam, her abdomen is distended and her bowel sounds are hyperactive. There is diffuse tenderness to palpation without rebound pain. An upright plane radiograph of the abdomen is ordered. Which of the following is the most likely finding on radiograph? Is it A, air fluid levels, B, thumbprinting, C, the double bubble sign, or D, an omega loop sign? Well, here the correct answer is A, the air fluid levels would be the most likely finding. Why is this? Well, this patient presents with findings that would be suspicious for a small bowel obstruction. Things that would make us think of this are the cramping abdominal pain, the progressively getting worse and starting only 2 days ago, and she can't remember her last bowel movement. Also, she has no emesis, and her abdomen is distended with bowel sounds that are hyperactive. The no rebounding pain makes us think that it's not appendicitis. Of note, it is important to remember that cholelithiasis increases the risk of developing a small bowel obstruction due to a gallstone ileus. She's at risk for having gallstones in her gallbladder. Remember the 4 F's: 45-year-old woman, 40s, female, and fertile. In order to make a definitive diagnosis of a small bowel obstruction, you require an upright plane abdominal radiograph, and this reveals air fluid levels in the bowel, hence why A is correct. Thumbprinting isn't correct since it's the pathognomonic radiograph finding for mesenteric ischemia. The classic presentation of acute mesenteric ischemia is severe abdominal pain disproportionate to physical exam findings. The pain is due to ischemia and possibly infarction, so we would expect her to be in a lot worse pain. Because of the gradual onset and worsening in this patient, the presentation in the vignette is not likely to be mesenteric ischemia. The double bubble sign in answer C is normally found on radiographs of patients with duodenal atresia. This is a congenital disease with the failure of the duodenum to recanalize. Remember, duodenal atresia is associated with Down syndrome. This doesn't apply to our patient here. Finally, D, the omega loop sign, is the classic radiographic finding of sigmoid volvulus, not small bowel obstruction. Therefore, again, A is correct with air fluid levels. Okay, let's do one final question to end GI pathology. A 23-year-old man who recently returned from a year in South America complains of progressive difficulty swallowing solids and liquids. He also complains of retrosternal chest pain that is precipitated by eating and accompanied by regurgitation that is not sour tasting. He has unintentionally lost 2.3 kilograms, or about 5 pounds, over the past 2 months, but he has not had any other constitutional symptoms. He does not smoke or drink, and he is HIV negative. Which of the following is the most likely diagnosis in this patient? Is it A, Barrett esophagus, B, Chagas disease, C, esophageal candida infection, D, esophageal squamous cell carcinoma, or E, tracheoesophageal fistula? The correct answer is B, Chagas disease. Let's go through this. So, in this patient, he complains of progressive difficulty swallowing solids and liquids. This signifies a probable neuromuscular dysfunction rather than a fixed mass, which you would see in esophageal squamous cell carcinoma, candida infection, or tracheoesophageal fistula. So we can cross these out. Fixed masses might be expected to cause only solid food dysphagia, not both solids and liquids. His report that regurgitated food doesn't taste acidified or sour tasting, suggesting that it hasn't reached the stomach's environment yet. This would locate the lesion to above the stomach and the lower esophageal sphincter. Achalasia is a failure of the lower esophageal sphincter to relax due to loss of inhibitory neurons of the myenteric or Auerbach's plexus. Achalasia can be primary or secondary. Here we have the clue that he's been in South America. This should make you immediately think of Chagas disease. Chagas disease is endemic to regions such as South America. And remember, it's Trypanosoma cruzi infection that causes destruction of the myenteric plexus of the esophagus. Achalasia usually manifests during young adulthood, but it can appear in infancy or childhood. The patient's weight loss here of about 5 pounds is probably due to the fact that he hasn't been able to eat. Imaging in this case would likely show a classic bird's beak appearance on barium swallow. An esophageal manometry would reveal hypertensive lower esophageal sphincter pressure and incomplete or absent relaxation with swallowing.